Hello, my name is Raghad Al-Abdawani. I'm a pediatric intensivist at Sultan Qaboos University Hospital. So I've compiled this basic, practical, and brief tutorial on non-invasive ventilation for healthcare workers who don't usually work at the pediatric ICU. So the objectives will be to discuss the different types of non-invasive ventilation. That includes high-flow nasal cannula, continuous positive airway pressure known as Cpap, as well as bilevel positive airway pressure, which is BiPAP. During the tutorial, we'll describe the different equipment that's used for NIV and how to operate them, and we'll describe the types of masks that we use, as well as the approach to assess a patient on NIV. So let's talk about the different types of non-invasive ventilation. So let's start with a humidified heated high-flow nasal cannula, also known as the Hyphenase Cannula. Now, strictly speaking, this is not a type of non-invasive ventilation, but it can be thought of as a bridge between low-flow oxygen and nasal Cpap. It isn't just a standard nasal cannula that's cranked up to very high flow rates. It actually takes the gas and heats it up to about 37 degrees with 100% relative humidity and can deliver oxygen at 0.21 to up to 100% at flow rates of up to 60 liters per minute. Now, in terms of the high-flow nasal cannulas available in SQ, we have two types. There is one that's available at the high dependency and at the ICU. These are ideal for patients between 4 to 8 kilograms because they can provide flow rates of about 8 to 16 liters per minute. The other one we have, called the OptiFlow, is available at the NICU, and we borrow it from them. It is suitable for babies between 2 to 4 kilograms. We tend to use high-flow nasal cannula on babies with acute bronchiolitis, which are mild to moderate, those post-extubation, mild to moderate bronchospasm, mild to moderate pneumonia, or heart failure. And for the purpose of our talk, with the high-flow nasal cannula that's available at our hospital, the babies need to be weighing between 4 to 8 kilograms. There are a number of contraindications for the use of high-flow nasal cannula. This includes critically ill infants and children requiring immediate higher level of respiratory support, meaning non-invasive ventilation or invasive mechanical ventilation, patient in shock, patients with severe upper airway obstruction, central apnea, severe asthma, blocked nasal passages or choanotresia, a patient with trauma or surgery to the nasopharynx or epistaxis, and a patient with pneumothorax. So how do we go about initiating high-flow nasal cannula? Now remember, these recommendations are for that type used in SQH. So we usually start with a flow rate of 2 liters per minute per kilogram. So if a baby weighs 6 kilograms, then 6 times 2, we would start with a flow rate of 12 liters per minute. Now this is also the maximum allowed flow rate, and if a baby is requiring more than that, then we need to escalate the type of NIV they are on. We also start them with a FiO2 of 0.6 and then wean the FiO2 as tolerated, aiming for SATs of 94 to 99%. Now we can start to wean the FiO2 as early as an hour after initiation of the high-flow nasal cannula. About 6 to 12 hours after stability and clinical improvement of the patient and after achieving an FiO2 of less than 0.3 with the aimed saturations, we can start weaning the flow rate by 2 liters per minute each time. We can wean as fast as every 6 hours or even as slow as every 24 hours, depending on the clinical status of the patient as well as diagnosis and pathophysiology of the condition. So let's say we started a patient on a flow rate of 14 liters per minute, then we go down to 12, and then 10, and then 8. Once we get to 8 liters per minute, we can trial the baby off the high-flow nasal cannula. It's important to remember that frequent assessments are required, and this includes the work of breathing, including retractions, tachypnea, grunting, nasal flaring, as well as improvements in tachycardia, oxygen requirements, and repeating the blood gas. It's ideal if we usually Repeat or start with a blood gas before the initiation of hyphenase cannula, and then repeat it about 60 to 90 minutes after the initiation of hyphenase cannula. Important things to note. Acutely unwell patients require careful observation and monitoring, as well as frequent respiratory assessments. If there is no improvement or there is worsening in the respiratory status, consider higher respiratory support, meaning non-invasive ventilation or invasive mechanical ventilation. Complications of high-flow nasal cannula include breath stacking, air leak syndrome, higher intrathoracic pressures leading to hemodynamic instability, and this usually occurs in patients who are hypovolemic. So let's move on to non-invasive ventilation. Now we have three types at SQH. We have the bubble Cpap, which we tend to borrow from NICU, the Trilogy 202, and Philips V60. The aim of non-invasive ventilation is to reduce the work of breathing and improve gas exchange. The use of non-invasive ventilation has been great in reducing the number of invasive mechanical ventilation. As you can see that over the years, there was an increase in the use of non-invasive mechanical ventilation and a decrease in the number of invasive mechanical ventilation that was required. And so by decreasing the number of patients who needed invasive mechanical ventilation, we reduced the number of nosocomial infections, decreased the need and degree of sedation, and decreased the bed demand at the PICU. We have two types of non-invasive ventilation. The Cpap, which basically provides a constant positive pressure throughout the entire respiratory cycle while the patient is breathing spontaneously. So we say PEEP, Cpap with a PEEP of, for example, 6 centimeters of water. And then we have the BiPAP. Here, the ventilator provides a preset positive pressure at inspiration, what we call the IPAP, as well as a background positive expiratory pressure, which we call the EPAP. So for example, we would say the patient's on an IPAP of 12 and an EPAP of 6 centimeters of water. The BiPAP offers more support than the Cpap. With the presence of the IPAP as well as the EPAP, the BiPAP is able to support the tidal volume via the delta P as well as the functional residual capacity. And so with that delta P, it helps in improving the ventilation as well as gas exchange, and it makes it more effective than using Cpap on its own. So generally speaking, if someone has a hypoxic respiratory failure, then we would use Cpap because the EPAP is important for oxygenation. However, if you have someone who's hypoxic and also has hypercarbic respiratory failure, so meaning the CO2 is also high, then BiPAP is a better fit as it helps in washing out the CO2. So if you look at the indications of non-invasive ventilation, it can be used in patients with mild to moderate ARDS. Having said that, at the time of presence of COVID-19, if a patient comes in with suspicion of COVID-19 as well as moderate ARDS, then one would not resort to NIV, but would probably resort to invasive mechanical ventilation. However, generally speaking, in other patients, if patients have either mild or moderate ARDS, NIV is definitely an option. It's also used for patients with pneumonia, bronchiolitis, asthma with an exacerbation, moderate in level, as well as moderate upper airway obstruction or mild upper airway obstruction, sickle cell acute chest syndrome, patients post-extubation if they needed some support, as well as patients who are coming in and known to have neuromuscular disorders or chest wall deformities and coming in with respiratory illness. There are a number of contraindications for the use of non-invasive ventilation. These are mainly patients who are apneic, patients with hemodynamic instability and hence in shock, patients who've just undergone CPR or are in peri-arrest state, patients with severe hypoxemia or low GCS such that they can't protect their airways or have status epilepticus, patients who've recently had a facial surgery or trauma to their face, patients with untreated pneumothorax, patients who've been vomiting repetitively or have a lot of secretions or are very agitated, patients whom have had a recent surgery to their GI system and so it can compromise the surgery that's been done, and also patients who have nasal obstruction or atresia or epistaxis. So how do we go about initiating non-invasive ventilation? The first question to ask ourselves is, are these signs and symptoms of acute respiratory distress or failure? If the answer is yes, does the patient require immediate intubation? If the answer is no, are there any contraindication to non-invasive ventilation? And if the answer is no, then we need to choose the best modality and interface based on the clinical situation. So if the patient has type 1 respiratory failure, meaning they have mild hypoxia, mild to moderate work of breathing, as well as no hypercapnia, then we would resort to the use of Hyphenase Cannula or Cpap. We tend to use Hyphenase Cannula if the patient's work of breathing is pretty mild and they're pretty small in size and or maybe irritable. The next thing is to look at patients who have type 2 respiratory failure, meaning they've got moderate to severe hypoxia, moderate work of breathing, as well as hypercapnia, which is CO2 of about 50. For those patients, we would resort to using BiPAP. For Hyphenase Cannula, the interface is set. It's there in the kit. As we mentioned before, we would start with flows of 2 liters per minute per kilogram and FiO2 of 0.6, and we would wean, aiming for sats of 94 to 99%. In terms of Cpap, we would usually use an interface of nasal mask or oronasal mask. We would start with PEEP of 5 and can increase all the way to PEEP of 10. So if the patient's work or breathing is not improving, we could increase it from 5 all the way up to 10. We would start the FiO2 at 100% and wean down to aim for sats of 94 to 99%. In terms of BiPAP, we could use either the nasal mask, oral nasal mask, or the full face mask. We start with an IPAP, meaning inspiratory positive airway pressure of 8 to 10. We would start an EPAP of 4 to 5, and we can escalate all the way to IPAP of 16 and EPAP of 10. Again, with the FiO2, we start with 100% and wean down, aiming for sats of 94 to 99%. It is important to be very meticulous in monitoring these patients, looking at their vital signs, the synchrony, the mask fit, as well as the blood gas, and we'll talk about this a little later. When we come to assess them, we assess them at the 30-minute mark, at 1 hour, 1.5 hours, and then a 2-hour mark, at which point we should then decide if we can continue on non-invasive ventilation or we need to escalate to invasive mechanical ventilation. So I'm going to talk about the different NIV machines available at SQH. This is the Trilogy 202. You'll find it in the high dependency as well as the PICU. I've labeled some of the important parameters and buttons for you to see. In the following slide, I'm going to show you a video of how to set it up and set up the parameters as well as the settings. Here, if you look at the PIP, this shows you the pressures that are generated during IPAP and EPAP. So let's say I set up a pressure of 12 IPAP on 6 of EPAP. This may oscillate between, let's say, 12, 11.6, 11.5 to almost 6, 5.5, or 6. So these are more like the achievable pressures, and it's important to look at them and see that they are close to what you have actually set. The next thing is to look at the tidal volume and ensure that the tidal volume is adequate for the patient. We usually like to aim for a tidal volume of 5 to 8 ml per kilo. So let's say a patient is 10 kilos. I would like to see this being between 50 to 80 ml. If the number is very small, look for the leak around the mask. That's usually the commonest problem. The next is to look at the leak. The leak is how much air is actually being lost from around the interface, meaning the mask. It should be 30 or less. Having said that, sometimes we have a leak of, let's say, 40, 45, but if the tidal volume that's being generated is good enough, we sometimes allow for it. Then you see the respiratory rate of the patient, and you can also see the FiO2 that we set for the patient. Now, other important parameters to note is over here you could see the ST. So when we place a patient on BiPAP, we usually put them on the ST mode. Or you would see Cpap over here if we put a patient on Cpap. This is the on-off button. This is the alarm button if you want to silence it. This button helps in selecting, modifying, and confirming parameters. This is to cancel action or exit the menu. And this is the buttons. These are the buttons we use to navigate the menu and change the settings. The Trilogy 202 can be used as an invasive mechanical ventilator or as an IV. Now we would like to use it as an IV. So in order to do that, what we would do is that we would press on the alarm button as well as the bottom button over here for a few seconds. You get the setup screen. So here we would go to settings and alarm, press select, and then go to circuit type and make sure that the circuit type is passive. So you can go to it. If you press modify, you can actually change it. So we want it to be on passive. You press OK. Check settings and alarm. OK. The next thing is to move to the mode of an IV that we would like. We have two options, Cpap or ST mode. ST mode is the BiPAP mode we use. So you can choose what you like. So here, if you press modify, you've got Cpap, you've got ST. We'd like it to be ST if we're on BiPAP mode. So we go to that, press OK, and then finish. Active ST mode, yes. And then finally, you press the exit button. Now the machine is ready for us to switch it back on and actually set the parameters we would like. So, click on. Okay, so here what we can do is that we can go to the menu by pressing the modify button. Once you go down, you will see the IPAP setting, the EPAP setting, the rate, I-time, as well as FiO2. These are the parameters that we would like to change. So for the IPAP, you could set, so let's say I wanted to put the patient on 12 on 6. So I would go to IPAP, press modify, change the number to what I would like it to be. Okay, go to EPAP, modify, change it, we want it at 6. Go to, and then let's say 6, okay. Go to breath rate, let's say we want the patient to be on a rate of 20. So these are 20 guaranteed breaths that the patient can take. Press OK. I-time, a good I-time would be anywhere between 0.8 to 1, so we'll leave it at 0.8. And we start the FiO2, let's say with higher than that, so let's say we could start with 100%. You can see going all the way up. 100%, okay. Once you are done with your settings, ensure that you press finish and then exit the screen. Now it is functional. Here are some things to note about the Trilogy 202. This is what the Philips V60 BiPAP machine looks like. If you look here, you can see the IPAP, the EPAP settings, the FiO2, as well as the sat rate in the ST mode of BiPAP. This is a touch screen, and so it's very easy to just press on the button and change the settings accordingly. Now, if we look over here, this notes the respiratory rate of the patient, the tidal volume, and as we said, we want to aim for 5 to 8 ml per kilo. The patient leak, we would aim for less than 30. And this is the percent of patient trigger. This means the percent of how many breaths are actually being triggered by the patient. So if the percentage is low, meaning less than 50% or less than 60%, then it means that there's either a large leak from around the mask or the patient is hypopneic. Now, it's okay for the patient trigger percentage to be low if the tidal volume is adequate and the patient is improving clinically. Now, we can set the Philips V60 BiPAP as a Cpap by just putting the IPAP and EPAP on the same number. So if we wanted a Cpap of 7, we would place the IPAP at 7 and the EPAP at 7. Now, things to note about Philips V60. It can be used for patients of 20 kilos and above, but off-label, we use it for those patients 10 kilos and above. Again, this can be used as Cpap or BiPAP. Remember again that the IPAP is the total pressure given during inspiration. FiO2 that's given can be as high as 100% on the BiPAP machine of V60, and we add a filter at the end of the tube close to the machine. And finally, we have the bubble Cpap. We tend to borrow the bubble Cpap from the NICU. We can use it in children from birth all the way to 12 months, so those less than 10 kilos. We always set the flow at 8 liters per minute, and the PEEP can go from 5 to 8 centimeters of water. We can administer FiO2 as high as 100%, and then wean it down, aiming for the sats of 94 to 99%. Now remember, when using any of the types of NIV, it is essential that monitoring is done regularly every half hour. A decision to continue NIV or escalate to endotracheal intubation must be done within the first 2 hours. When we talk about monitoring, we mean looking for improvement in tachycardia, tachypnea, respiratory distress, improvement in oxygen requirements, meaning that we're able to wean the FiO2, improving in the SF ratio, which is the SATs over the FiO2. So if this SF ratio is increasing, that means that the patient is improving. Improvement in the blood gas, and ideally, we would do the blood gas before starting and then 60 minutes to 90 minutes post initiation of the NIV. We would look for no development in any contraindications of NIV, for example, low GCS or shock, and we would ensure that the leak, percent trigger, achievable pressures, and tidal volumes are all adequate. A few things to note. Please alert the PICU team for any patient you have on BiPAP or bubble Cpap above a PEEP of 7 or on high flow nasal cannula and not improving. Now, it's important to remember that good patient cooperation and synchrony needs to be established. An IV can be provided using total face mask, oronasal mask, or nasal mask only, but our experience are that total face mask seems to work best on infants. Always ensure that the difference between the IPAP and EPAP, known as delta P, is at least 5. Usually the settings we use are IPAP, EPAP of 8 on 4 or 10 on 5, 12 on 6, 14 on 7, 16 on 8, or 16 on 10. Now, some infants and children need some form of sedation to tolerate the face mask. So we tend to use chloral hydrate, 20 to 40 milligrams per kilo per dose, Q6 hourly PRN. If a patient also has bronchospasm and needs more than just chloral hydrate, we tend to use a ketamine infusion of 15 to 35 mics per kilo per minute. Another drug that can be used is midazolam infusion, 0.5 to 1 mics per kilo per minute, but we avoid these in patients 12 months and below. We do not use ketamine and midazolam together. It's either ketamine or midazolam, but often with chloral hydrate and non-pharmaceutical methods such as calming the baby down, with the use of mom, using pacifiers, sometimes starting feeds once they start to settle down, we're able to get the children to settle without using a lot of sedatives. Complications include air leak syndrome, meaning pneumothoraces. Patients can have decrease in cardiac output due to increased intrathoracic pressure, especially in the setting of hypovolemia. Gastric and abdominal distension that can lead to aspiration pneumonia. Having pressure sores, especially at the nasal, facial, and scalp areas. Patients being agitated or uncomfortable. This could be due to leak around the interface. Having failure to synchronize, being hypoxic or having anxiety. And finally, desynchrony. And one can help the desynchrony by sedating the patient or changing the interface or even the settings. How do we wean the NIV? After 12 hours of clinical improvement, one can consider weaning. We start weaning the FiO2 from as early as the first hour of placing a patient on an IV. We would wean the FiO2 until we can get to less than 30%. After achieving improvement in the work of breathing, secretions being under control, improved vital signs, blood gas, as well as FiO2 being less than 30%, then we can start weaning the pressures. We tend to wean the IPAP by 2 centimeters of water each time, and the EPAP by 1 centimeter of water each time, as frequently as every 8 to 24 hours, depending on the repeated assessments of the patient's clinical picture, diagnosis, pathophysiology of the disease, and their past history. Once the patient's settings are 10-on-5 or 8-on-4, then the patient is ready for trial off the BiPAP. At times, patients may be weaned from BiPAP down to either use of Cpap or Hyphenase Cannula if the patient doesn't do well when we trial them off the BiPAP. Sometimes patients with chronic illnesses like chronic lung disease or neuromuscular disease may require cycling off the BiPAP, meaning they can't tolerate just going off the BiPAP altogether. They may need for us to take the child off the BiPAP for an hour, see how they do. If they're doing well, take them off another hour later in the day. By the following day, we could try them off for 2 hours twice a day, and then maybe 4 hours twice a day, and then maybe off the BiPAP during daytime, and then decreasing number of hours of being on BiPAP even nighttime. This is tailored to each patient individually. I have not placed a slide for summary, as I think that every slide is pretty concise and important. If you have any questions or clarifications, please don't hesitate to email me at raghadalabdawani@gmail.com or Dr. Najwa at najwarahbi@gmail.com. Thank you.